My name is Jerry Lewandowski. I'm with the PMP Research Foundation, and Laura invited us here to help with the symposium today, and she asked if I would help coordinate some question and answer during the lunch. So thanks again for having us, Laura. And I guess we can start with questions from the field. If anyone has questions that you want to be debated or for a particular person, Jim Carroll has a microphone, so hopefully we can hear. But does anybody have a burning question? Okay, well, I'll kick it off. And if anyone thinks of anything, feel free to just raise your hand and Jim can come try to find you. There was, Dr. Pingpank mentioned the recent Sloan Kettering study, which was sort of an update of their study showing that cytoreductive surgery without HIPEC followed by periodic intraperitoneal chemotherapy, they seem to be showing as effective as cytoreductive surgery with HIPEC at the time of the surgery. And I just wonder if it seems like those are different results than I've seen from Sloan Kettering before, and I wonder if you have any reaction to the difference or how to compare the two methodologies.
It is a little bit like comparing apples and oranges. The Memorial Sloan Kettering series, a lot of those patients did get intraperitoneal chemotherapy, and the first study that they published was comparing cytoreduction, just the surgery alone, and comparing it to cytoreduction with intraperitoneal chemotherapy, not the heated intraperitoneal chemotherapy. And the results, so that kind of confused the issue a little bit with the patients that got intraperitoneal chemotherapy, and so it's it's hard to compare it's hard to compare two studies to know if the histologies were the same, or and you're selecting patients who could undergo multiple surgeries that were well enough to undergo multiple surgeries. So you're wondering, what was the magnitude of the surgeries that they were having with each surgery. And it's absolutely an important question, and it's one that hasn't been answered yet. We absolutely don't know the role of the heated intraperitoneal chemotherapy at this point. We do know that our ability to get a complete cytoreduction at the time of surgery is the most important thing. We think then that the heated intraperitoneal chemotherapy will help based on the fact that we think that it's killing microscopic cells that are left behind. And for patients with the low-grade mucinous tumors of the appendix, we see people who are cured, people who are 20 years out with no recurrence of their disease. But what we don't know, we don't have the study that's compared surgery alone versus surgery and the heated intraperitoneal chemotherapy. I mean, that would be the study that would determine whether the heated intraperitoneal chemotherapy really plays a role, or is it really good surgery and the tumor biology. And that's the other thing that's always going to drive the outcome. Many people may be aware that Dr. Esquivel and Alex Stojnovic, I can never say his last name, have spent over a decade trying to put together a randomized control trial for people to get for people to be divided into two groups. One group gets intravenous chemotherapy, the best intravenous chemotherapy that we have, and the other group, the patients would get surgery with heated intraperitoneal chemotherapy followed by intravenous chemotherapy, and see which group does better. And after a decade of working to get this through all the political bodies that it needed to go through and the approval, it was available for a year, and unfortunately they were only able to recruit one patient on the study. And the reason for that is because people know that cytoreductive surgery and heated intraperitoneal chemotherapy is available. They see these results that are published by Dr. Sugarbaker that are truly encouraging. And when somebody comes to the surgeon and they say, they're coming thinking that they're going to hear a discussion about surgery and heated intraperitoneal chemotherapy, and then the surgeon says, well, I have this trial, would you consider you're going to be randomly selected to either have the surgery or intravenous chemotherapy, and then we're going to see what's going to happen. Well, nobody wants to sign up for that. It's understandable. So we're still working out the best way to really drill down on whether the heated intraperitoneal chemotherapy has a significant benefit. We know that the surgery is very beneficial. And then the other question, the question that I get asked all the time, and I'm going to ask Dr. Switzer to comment on this, is, what about just putting chemotherapy in the belly cavity? Why can't you just put a catheter in and do multiple washings with chemotherapy and put it directly on the tumor? And why are we doing it intravenously? I'll answer a little bit the knowledge that I have about that, and then I'll ask Brad if he has any other thoughts. So right now there are a number of phase 1 clinical trials. Phase 1 means that the study is being done to look at whether or not people can tolerate the treatment, whether it's safe, and to find a dose that is safe that people will be able to take before you go to the next level of a trial, which looks to see, is the drug working, is the treatment working? And we haven't really gotten to that step yet with intraperitoneal chemotherapy without cytoreduction. And so we know that people can tolerate having chemotherapy put in their belly cavity, having a catheter put in and getting multiple doses of chemotherapy in the belly cavity. We do that all the time, actually, for ladies with ovarian cancer. It's actually the standard of care of treatment for ladies with ovarian cancer to get that as an outpatient. But with colon cancer or appendiceal cancer, all we have so far are the phase 1 studies to show that people can tolerate it. Now the next question is, does it help? And I think it makes sense to think that it would help, and it probably would help in the setting of a good cytoreduction is probably when it will help the most. And I think we're going to start seeing some of that coming soon. But right now, it's not readily available things that we can do easily off of a clinical study.
So how do you follow that? What I'll say is, I'll start off to kind of start with your question, then answer her question, is that when you're comparing these trials, they're very difficult to compare. And they're definitely apples to oranges. So as I kind of showed you in my presentation, that there's definite differences in pathology and people's response versus how their tumor is described, how aggressive their tumor is. So if patients have poor differentiation or signet ring features, they're going to be way down on the curve as far as how well they're going to do. And so when you're comparing studies, you actually have to look very closely about how much of which type of patients, because appendiceal cancer isn't appendiceal cancer. Right. It definitely depends on how aggressively it behaves. So a lot of these studies they're very difficult to compare because how many of them had aggressive histology? How many of them had very mild histology that would be very amenable to just surgery alone, and maybe may not benefit from systemic chemotherapy, or other types of chemotherapy. So I think that this is definitely a plug that we as a cancer body, doing research in this area, we need to do better. And there's several people at this table and several people across the country that are motivated to start making a lot more effort and a lot more concentrated effort to try to tease out the little differences between the tumor types, and find out if maybe it's helpful in the lower aggressive patients, but not as helpful in the higher aggressive patients, and it's not quite clear yet. And right now we're kind of lumping them all together, and when you're lumping them all together, that's why you have some people that say, oh yeah, I had this and I'm doing great 10 years later, and you have somebody say, wow, I'm not. And I think it has to do with the biology of the tumor. So to answer Dr. Lambert's question is about systemic chemotherapy versus localized chemotherapy. I kind of gloss by it, but when you're bathing a tumor, it's kind of think of like bathing your skin. If you sit in a bathtub for 45 minutes, your skin gets kind of puffy and it kind of absorbs a little bit of it. But it's not that you don't need to drink for the rest of the day because you absorbed enough fluid so you don't have to drink. So it's kind of the same principle in a sense that that if there's a small bit of tumor, if there's a couple of layers of tumors, I mentioned appendiceal cancer tumor, appendiceal tumors they're known for kind of layering across the surface of tissues. If there's a couple of thin layers, less than 3 millimeters or so, then it's very reasonable that it's theoretically possible that the best treatment for it would actually be just bathing it in the tumor, bathing it in the chemotherapy and letting it soak it up. But if you have this big ball of tumor, you're only going to get the outer layer of it, and the inner portion of the tumor is not going to be affected. So there's a lot of different theories about why that's going to happen and about how we can do this. And so there's a lot of different studies. And so some studies have shown, some of the older studies show that IV chemotherapy didn't work, and then intraperitoneal chemotherapy didn't work, and then surgery appears to be the best thing, because if you can get most of the tumor out safely, then that's the best thing. But what do you do next? And I think that's where we're really at now, is that what combination in what order is the best, and we're working on it.
Well, and that's, I guess, as one follow-up question, as I look at the panel, it's obviously, a group of people who are working together in different ways to treat patients with the same condition. Is there anything that you feel like you all see eye to eye on and it sort of works seamlessly, versus what are the things that are wrinkles between, trying to figure out the pathology and how you're going to treat it? Are there differences of opinion, and how do you work through those things in terms of what you do first versus second versus third?
Since I have the mic, I'll start first. What I would say, and this is where being at a large academic center or a center that does this is important, because we meet every week at a multidisciplinary tumor board with 1 or 2 pathologists, a couple of radiologists, several medical oncologists, several surgical oncologists, radiation oncologists, and we all sit down and we discuss this, and we kind of have polite, pleasant arguments about what we feel strongly is the best treatment options for patients. And so I think just having the system set up so we can have that dialogue is the most important thing. If you're at a place that has all the same disciplines, but they don't meet on a regular basis and communicate well with each other, that's where things break down, and you kind of get the treatment that you get referred to first. So if you see a medical oncologist first, you get chemotherapy first, and if you see a surgeon first, you get surgery first. And I think that's why the push is to send people to centers that do have this on a regular basis, have meetings and dialogue very well about this.
And I think that the point that Dr. Switzer just made, that this multidisciplinary approach is so important. One of the things is that we actually kind of come up with a protocol of how we're going to treat people. So if somebody comes in with a diagnosis of a signet ring cell or a poorly differentiated, we have agreed that, mostly between Dr. Switzer, Dr. Bethany, and myself, we have agreed that those people are going to get intravenous chemotherapy up front. That is based on not only what we're seeing here, but what we're seeing across the country, and other people are talking about this. The signet rings and the poorly differentiated are really responding to chemotherapy, and there's a window of opportunity at about 3 to 4 months after the chemotherapy where we're probably seeing the maximal response to the chemotherapy, and that is an opportunity to think about going for surgery at that point in time and see if there's really hardly any tumor there, or we can get a complete tumor debulking, then we could do the heated chemotherapy and then finish the complete course of the intravenous chemotherapy. That's just an example of, we talk amongst ourselves, we say this is going to be our plan, and it's a starting point so that if I see the patient first, or if Dr. Switzer sees the patient first, they're going to get the same message, and then it may turn out that data comes out that actually we should be doing the surgery first, or we should be waiting 6 months, and then we can adjust from there. But at least we're all starting from the same point. But we rely very heavily on what Dr. Kim sees on CT scans or MRIs, and what Dr. Walter's telling us he's seeing under the microscope. So that's why it's important that they're at our meetings, because Dr. Kim's got the films up and we're reviewing them with him and seeing the same thing, and Dr. Walter's putting up the slides and is showing us, this is what I'm seeing and this is what you need to be focusing on.
The other thing, many times these patients are coming from other institutions where, as I showed, given the different nomenclatures running in this describing the same disease processes, it's really important that the clinicians and the diagnostic field speaks the same language. So the review of these slides are usually needed and necessary to be sure that we are talking about the same disease process. So we always review the slides before these surgeries.
I think the one last piece that the multidisciplinary that's so important from where I sit in the multidisciplinary team is that each patient that's presented is a real person and an individual who has a set of limitations or not, that often just because we have a treatment, it doesn't mean that it's a treatment that that individual can go through or has the supports for, or we need to line this up or do that. I mean, in our institution, we're very fortunate to have Hope Lodge. And so because Dr. Lambert's name is out there both nationally and internationally, you know, we've had people come from Iceland and from all kinds of other places. So they may physically be someone who can go through the heated intraperitoneal chemotherapy and the afterwards. But as Lindsay said, this is, and I always tell patients, this is bigger than being hit by a truck. You know, that it's, and I see my patients all shaking their heads, you know, that it's not an easy surgery. And so sometimes the way that we stagger things, it gives people a test of time to see. It's one of the other things that I think is unique in this particular disease state is that they really take that into consideration, and you know, physicians take an oath of do no harm, and they really balance that very carefully all of the time.
Is there a particular like class or course or something that they have to notice or be attentive to diseases like this? Anything that's not the norm, you know, not like a, you know, stomach cancer or breast cancer or whatever. Is there a way to make them aware of things that aren't as, you know, out there as breast cancer or anything that people know of?
Yeah, that'd be great if there was a course in rare diseases. Unfortunately, there's not a dedicated course for that. Certainly here the students see a lot of appendiceal cancer. So I'm always pointing out when I have a student come to my clinic with me, I say, you know, I have them look at the list, and there may be 5, 6, or 7 people in the clinic that have appendiceal cancer, and I tell them, you're never going to see this again, and they pay attention because it's interesting. You know, you're not going to see, you know, 6 or 7 people with appendiceal cancer in a single clinic again. I'm sure, Brad, your list is probably looking like that these days as well too. So, no, and unfortunately, I think we're, you know, the students that we're lucky to have rotate with us I think they will remember the cases that they see. And hopefully, like as Doug was saying, it's kind of a grassroots movement, and one person tells another person tells another person. I think they will take this forward with them when they go on to whatever career they go on to. And even if, you know, they're a primary care doctor or they're a radiologist, or, you know, they're going to remember back and say, oh, this person needs to get in to see somebody. You know, I hope that's what'll happen. Yep. Yeah, I really think that, you know, when they see people with appendiceal cancer and they hear their stories and they see the surgery, I think it's something that they never forget. Yeah.
Okay. Hey, Jerry, I have a question for Dr. Kim. Assuming a patient can handle an MRI, are they as good at detecting disease or not?
The question was, MRI, if the patient tolerates the study well, MRI can be as good as a CT scan. Simple answer is yes. Simple answer is yes. If the patient can tolerate means patient can be stand still in the MRI scanner room for a minimum 40 minutes, and the patient bowel, better not to move, but you cannot control the bowel movements, as I show you. So some people's the bowels are very quiet at the time of scanning. And that circumstances, the MRI can be as good as a CT. And then, as Dr. Switzer said, MRI can be better in detection of certain very tiny lesions in the liver, on the peritoneal lesion, using I didn't include the slide, using the new technology such as diffusion-weighted images, can detect a very tiny little lesion under the assumption that study should be done very nicely. That answer the question?
Thank you.
Actually, I want to add a little something to that. Just because I mentioned a study, and I don't want to confuse anybody. So people who have a lot of tumor, it's very easy to see by scan. It's this kind of this subtle growth along the top of tissues that can be very underrepresented by CAT scans and MRIs. And so we do need to get a little better at it. And I think one of the studies that I quoted was that when they first diagnosed a patient, they went in and looked around with a camera, a laparoscopy, and they kind of said this is how much tumor that they have. Then we treated them. I didn't say we, but as a community, the patients were treated, and then they went back in again with another camera and they looked again, and they compared the CAT scan to the camera, and they found in over 50% of patients, the CAT scan underrepresented what was actually seen when they went back into looking with a camera. And so for patients with a lot of disease, it's not that we can physically see the difference, but it's for these patients with very minimal residual disease, this very small amount of cancer left, that's very difficult. For the best radiologists and everybody. So for those of you that have had this kind of difficult conversation with your oncologist to say, well, I think it looks about the same, it's technical limitations of the scans we have so far. And I think there's some new advances that we're optimistic are going to be more useful than we currently have right now.
And from a surgical standpoint, I think this is a hugely important point, because I know a number of people unfortunately get disappointed at the time of surgery. So as we're planning our surgery, we look at the scan, and we look at the scan to determine whether we think somebody can get a complete tumor removal at the time of surgery. And there are some obvious findings that we see that we would say, no, I can't recommend the surgery. I really don't think we can get a complete tumor removal. But there's a couple of things that can happen at the time of surgery. One is what Dr. Switzer was just alluding to, is that the CT scan has just underestimated how much tumor there is, and it's because it's these very small little tumor nodules that are on the bowel or on the mesentery, which is the blood supply to the small bowel, and that is just something that we just can't see very well by any imaging. The other thing that is very hard to tell by scan is what I call sort of the stickiness of the tumor. So it may look like on the CAT scan that you can get in there and it should come right off, but sometimes you get in and the tumor itself is just more stuck to everything, and it can be stuck to the point where now you would have to remove too much of the intestine for a person to really have any ability to maintain their nutrition after surgery to get all that tumor out, and you have to unfortunately stop at that point. So those are some other areas of interest in terms of improving our ability to predict or see with radiology that concept of that stickiness or invasiveness and these little tiny tumor nodules that we just can't see.
One question I think comes up a lot and came up when we asked people for questions coming into today is where you feel like, and this probably works for medical oncology, surgical oncology, and pathology to some degree, where do you think the world is right now on some of these chemotherapy assays that are being developed to try to, in the old days you had sort of, here's the protocol if you have this type of cancer, but now people are very interested in personalized medicine, and somebody's going to test my tumor and tell me this is the drug that will completely knock it out. And that's an evolving field, so where do we feel like it is and how it matches up with tumors of this sort?
So I think that by itself is an entire week-long conference. But what I'll say is that we are emerging. We're in the early stages of personalized medicine. So to remove ourselves from appendiceal cancer, it's been in lung cancer. They found a specific mutation that if we target this specific mutation, people can live twice as long. In colon cancer, we talked about a good example of that is if there's a specific mutation that the pathologist can reliably check for, called KRAS, and if you don't have this mutation, a medication will work better than everyone else. So in a lot of the older studies where they just kind of gave everybody the same thing, it might not have worked because they didn't select the right people that would have the best benefit from it. So we're definitely kind of emerging into a field, into an area in oncology, which is a very exciting area, because we can really tailor. We're coming to a point where we can tailor treatment to the specific patient and the tumor. You asked specifically about these assays. There's something in colon cancer called, well, I'll say there's something in breast cancer which is much more universally accepted. There's a lot more literature out there about it. It's called Oncotype DX. I'm sure some of you have heard about it. It gives you a risk score of what the likelihood that your tumor will come back. And there's actually some good literature to say if we can treat here, we can make a difference for it. In colon cancer, they have a similar assay. It's significantly different. They have 21 genes that they're more than that genes that they're looking at. And depending on which ones are turned on and turned off, in colon cancer, after they take out the tumor, it can kind of predict risk. It hasn't gotten to the technology hasn't got to the point yet where we can say, so if we predict the risk, can we do anything about the risk? So by giving chemotherapy, can we change that risk of it coming back? The answer is not. We don't know that yet. What I would say is, coming back to appendiceal cancer, is that, it's already a pretty rare disease, and I've kind of talked to you about 5 to 6 major histology subtypes. When we start diluting out those histology subtypes into further and further things, honestly, we may not be able to fully say confidently that this one medication is the best thing for you. We'll probably have to extrapolate from other tumors, such as ovarian or colon or breast or something along those lines. Does that kind of help a little bit? I don't know if anybody else wants to.
Brad, what about, though, the chemotherapy assays where people send their tumor and they run it through a panel of different types of chemotherapies to see which one the patient should get specifically? What's the status of those right now?
So, as we all know, healthcare in America has its pluses and minuses. I would say that, in my humble opinion, I'd say that these are kind of in still the experimental phase. I think that the key thing is that theoretically it's a great idea, and I think that a lot more research needs to be done on this. But just because when they take your tumor out and they put it on the bench and we put chemotherapy to it, it works better there. Is that going to translate into better survival for you as a patient? And the answer is we don't know yet. It's a good theory, and I think that we need to continue doing more work on it. The problem is that there's a much lower standard for device companies as compared to drug companies. So drugs, you have to go through these huge trials and prove that it actually works. For devices, you don't really have to do that. So there's a lot of publicity out there. There's a lot of marketing out there because people want to sell this because they can make some money off of it. And I think that there's some good scientific rationale and foundation behind it, but we don't know yet. It's too early to say that by doing this, can we make a difference? Will this targeted treatment actually translate into improved survival? We don't know yet. So I'd say the short answer is it's in the early phases, the infant stage phases, has a lot of good promise, but I don't think, I'm not ready for prime time.